A very good day to my examiner and also to my classmates. A stroke rehabilitation is often discussed in physical terms. Muscle strength, mobility, respiratory function, and prevention of complication. However, recovery after stroke extends far beyond physical rehabilitation. It involves a profound psychological adjustment. Patients frequently experience a loss of independence, altered identity, and emotional vulnerability. When an autonomy is threatened, resistance may emerge, not as defense, but as a distress. In rehabilitation setting, this distress can manifest as a refusal of physiotherapy or withdrawal from care. If such resistance is interpreted solely as non-compliance, communication may become directive and task-focused, potentially weakening therapeutic rapport. This presentation examines how therapeutic communication, grounded in nursing theory and counseling principles, transform patient resistance into engagement and produce measurable clinical outcomes. Let me introduce myself. My name is Priya Tharsini, anak perempuan Arunasalam. My metric number is 9603080856600001 and I'm coming from Petaling Jaya Learning Center. So this presentation is structured to demonstrate a clear progression from problem identification to clinical resolution. I will begin with the case overview and examine both clinical and psychological risks associated with a rehabilitation refusal. Next, I will discuss how ineffective directive communication may unintentionally reinforce resistance. The presentation will then explore the transition to the therapeutic communication, integrating Peplav's interpersonal theory, Rogers' core condition, and motivational interviewing techniques. Finally, I will evaluate measurable safety outcomes, treatment adherence improvement, and implication for nursing practice before concluding with the key clinical insights. Before we explore the case, it is important to clarify the direction of this presentation. By the end of this section, we will move beyond simply describing a patient scenario. We will analyze the psychological impact of stroke on rehabilitation engagement. We will differentiate between directive communications, which focus on task completion, and therapeutic communication, which addresses emotional barriers. We will apply Peplav's interpersonal theory and Rogers' core conditions not as an abstract concept but as a practical clinical choice. We will integrate motivational interviewing strategies to enhance treatment adherence. And most importantly, we will evaluate how communication directly influences patient safety, recovery trajectory, and professional nursing practice. This presentation is therefore not only about what happened, but why it changed. Stroke rehabilitation involves both physical and psychological adjustment. Patient may experience a loss of independence, altered identity, and emotional distress. This distress can manifest as a resistance to the physiotherapy. If resistance is misinterpreted and non-compliance, communication may become directive rather than therapeutic. This presentation examines how evidence-based communication strategies transform resistance into engagement. During my clinical placement in rehabilitation ward, I encountered a patient who said something that really stayed with me. When I encouraged the patient to attend physiotherapy, he looked down and said quietly, "I give up." This is not a theoretical scenario. It was a real clinical interaction. At first glance, the issue appeared straightforward, a patient refusing rehabilitation. However, as I reflected on that moment, I realized the problem was not physiotherapy. It was a psychological distress. The statement reflected a loss of independence, altered identity, and emotional fatigue. In that moment, I understood that continuing with the directive instruction will likely to increase resistance. What was required was not a persuasion, but a therapeutic engagement. This real clinical experience became the foundation of my analysis, and it demonstrated how communication can function as a structured clinical intervention rather than a simple conversation. Following that interaction, it is important to present the case objectively. The patient was a 68-year-old male with post-cerebrovascular accident and left hemiparesis. He was dependent in activities of daily living and required diaper use due to incontinence. He demonstrated low mood and reduced motivation. Most significantly, he repeatedly refused physiotherapy sessions. From a clinical perspective, this raised concerns regarding the immobility-related complications. From a psychosocial perspective, it suggested difficulty adjusting to functional loss and altered self-concept. This dual dimension, physical risk and psychological distress, required a communication approach that addressed both. Therefore, the focus shifted from simply encouraging participation to understanding the meaning behind the refusal. From the clinical standpoint, the patient's refusal of physiotherapy was not a minor issue. Immobility significantly increases the risk of deep vein thrombosis due to venous stasis. Reduced chest expansion predisposes the patient to atelectasis and pneumonia. Prolonged pressure over body prominences increases the risk of pressure injuries. Muscle atrophy and joint contracture may develop rapidly without active rehabilitation. In addition, extended hospitalization increases healthcare costs and caregiver burden. In this context, refusal of physiotherapy directly compromises patient safety. However, what became clear during this experience was that clinical risk alone does not automatically motivate participation. Understanding the risk is important, but addressing the emotional barrier behind refusal is essential. These realizations guided to the next phase of communication. Beyond the physical risk, the deeper challenge was psychological. The patient experienced loss of independence, altered body image, and reduced autonomy. Requiring assistance with the basic activities of daily living disrupted his previous identity as a capable, self-sufficient individual. Incontinence too contributed to feelings of embarrassment and diminished dignity. Fear of permanent disability intensified withdrawal. Post-stroke depression affects approximately 30 to 50% of survivors, and emotional distress is strongly associated with reduced rehabilitation participation. In this context, the refusal of physiotherapy was not a defiance. It was a psychological distress expressed behaviorally. Recognizing these distinctions was critical before implementing a therapeutic communication. In the initial interaction, the communication approach was directive. The patient was told, if you don't do physiotherapy, you won't walk. Although factually correct, this statement focused on outcome rather than emotion. Directive communication may unintentionally increase defensiveness, particularly when a patient is already experiencing psychological distress. Instead of motivating participation, it reinforced withdrawal. The message emphasized consequences but did not explore underlying concern. This moment highlighted that providing information alone is insufficient when emotional barriers remain unaddressed. A different communication approach was required. Recognizing that directive communication was not effective, the approach shifted intentionally towards therapeutic communication. Instead of emphasizing consequences, the focus moved to understanding the patient's perspective. Open-ended questioning was introduced, active listening replaced instruction, empathetic reflection was used to validate emotional experience. Rather than saying what should be done, the nurse asks, "What worries you most about the physiotherapy?" This question changed the dynamic of the interaction. It signals respect, curiosity, and willingness to understand. The conversation moved from task enforcement to emotional exploration. That shift created the foundation for engagement. To better understand the shift in communication, Peplau's interpersonal theory provides a useful framework. Peplau conceptualized nursing as a therapeutic interpersonal process. In the orientation phase, the focus was on establishing trust and clarifying expectation. Rather than persuading the patient, the goal was to build a psychological safety. During the identification phase, emotional barriers were explored, including fear, shame, and perceived loss of identity. In the exploitation phase, the patient began utilizing the therapeutic relationship to express concern and gradually engaged in rehabilitation. Finally, in the resolution phase, independence was reinforced as the patient demonstrated increased participation. Peplau's framework illustrates that behavioral change was not immediate. It emerged through a structured relationship process. While Peplau explained the therapeutic processes, Rogers' core condition clarified the quality of the interaction. Rogers identifies three essential elements for meaningful change: empathy, unconditional positive regard, and genuineness. Empathy allowed the nurse to understand the patient's emotional experience without minimizing it. Unconditional positive regard ensured that the patient was treated with dignity regardless of his resistance. Genuineness maintained authenticity within the interactions, preventing the communication from feeling forced or scripted. This relation condition introduced defensiveness and restored psychological safety. When the patient felt understood rather than corrected, engagements become possible. Rogers' framework highlights that the effectiveness of communication depends not only on what is said, but on how it is conveyed. While Peplau and Rogers provided the relational foundation, motivational interviewing addressed behavioral changes. The patient demonstrated ambivalence toward the physiotherapy. Rather than confronting this ambivalence, it was explored. Open-ended questions encouraged reflection. Self-efficacy was strengthened by highlighting previous achievements. When asked, "You managed your business before. What strength helped you succeed?" the patient identified discipline and persistence. This shifted focus from limitation to capability. Motivational interviewing works by eliciting internal motivation rather than imposing external pressure. As the ambivalence decreased, participation gradually increased. This technique bridged emotional understanding with behavioral action. At this stage, ladies and gentlemen, therapeutic communication translated into practical counseling strategies. The patient's emotional distress was acknowledged rather than dismissed. Frustration and fear were normalized as an understandable response to stroke. Disability was reframed as a transitional phase within the rehabilitation rather than a permanent state. Small measurable goals were introduced to reduce overwhelm. For example, maintaining unsupported sitting balance for 5 minutes. This approach shifted focus from a long-term uncertainty to a short-term achievable progress. Incremental success restored confidence and strengthened engagement. In this way, Counseling skills provided structure to emotional support and facilitated behavioral changes. Following therapeutic engagement, observable clinical improvements were noted. The patient began participating in assisted mobilization section. Respiratory expansion improved with increased activity and effort. The risk of immobility-related complications such as a deep vein thrombosis and pneumonia decreased as the mobility increased, and adherence to repositioning schedule improved. These outcomes were measurable and clinically relevant. Importantly, the physiotherapy protocol itself did not change. What changed was the communication approach. This demonstrates that the therapeutic communication directly contributed to improved safety outcomes. Prior to therapeutic intervention, the patient consistently refused physiotherapy session. Engagement was minimal and cooperation was limited. Following the implementation of therapeutic communication strategies, gradual behavioral change was observed. The patient demonstrated increased tolerance for physiotherapy. Participation became more consistent. He required less prompting and showed a greater willingness to engage. Adherence developed through relational trust rather than coercion. This shift illustrates that sustainable participation is more likely when patients feel understood rather than pressured. In addition to improved participation, ladies and gentlemen, emotional changes were observed. Before the therapeutic engagement, the patient expressed hopelessness and demonstrated emotional withdrawal. Eye contact was limited and the verbal interactions was minimal. Following structured therapeutic communications, the patient began expressing cautious optimism. Verbal participation increased, interaction with healthcare staff became more consistent and cooperative. These changes suggest that the emotional engagement preceded sustained behavioral improvement. Addressing psychological distress allowed rehabilitation to progress more effectively. Ladies and gentlemen, now let's move to the impact on nursing practice. Therapeutic communication reduced nurse moral distress. Trust strengthened, interprofessional collaboration improved, communication influenced not only patient outcomes but professional practice integrity. Now, let us think, what if communication was ignored? If emotional barriers were ignored, complication risk will be increased. Hospitalizations will be prolonged. Emotional deteriorations will worsen. Healthcare costs will rise. Communication is therefore a patient safety competency. This case demonstrates that resistance in stroke rehabilitation is often a manifestation of psychological distress rather than non-compliance. When the communication remains directive, withdrawal may deepen. However, when the therapeutic communication is applied intentionally, guided by Peplau's interpersonal process, Rogers' relational condition, and motivational interviewing, engagement can be restored. In this case, safety improved, adherence increased, and emotional participation returned. The physiotherapy protocol did not change. The communication did. Therapeutic communication is not an optional soft skill. It is a clinical intervention that directly influences patient safety, recovery, and the integrity of nursing practice. These references provide the theoretical and empirical foundation supporting in this case analysis. Before I finish my presentation, I would like to leave you with one reflection. In rehabilitation nursing, we often measure progress in steps walked, muscle strength and function regained. But sometimes the most critical movement is not the physical, it is emotional. It is the moment a patient chooses to try again. This case reminded me that recovery does not begin with force, persuasion, or authority. It begins with connection. Because when patients feel heard, they participate. When they feel respected, they engage. And when they feel supported, they recover. Therapeutic communication is not an additional skill. It is the bridge between clinical knowledge and human healing. Thank you.